Hi, welcome you all for the KNO classes. This is your Nagraj, your NORCET mentor, NORCET guide. In this video, we're going to deal with the atrial blood gas analysis. If you see last exams and all, the exam is like too much interested in a ABG. They're giving you normal ABG parameters and they will ask you like interpret the ABG, given ABG. And in NORCET 7 mains, if you see, they asked a question regarding whether it's uncompensated ABG or partial compensated ABG or completely compensated ABG. And in 2025, in a JIPMAR skill test, they asked a Allen test. How will you perform the Allen test for a before taking the ABG? So too much the exam is too much interested in a arterial blood gas analysis topic. So in each and every examinations, there will be a must and should. One question will be one or two question up to five questions. They may ask you in a atrial blood gas analysis ABG series. So once at a time, we'll settle the whole topic till blood gas analysis, including the interpretation, including the analysis, including the validation from basics to complex. We'll start from basics. I'll clear the whole concept, whole complex topic also. So without delay, if you see why the examiner is too much interested in ABG and why the consultant, why the ICU intensivist is most concerned about the atrial blood gas analysis. If you see patient admitted in ICUs, in a critical care areas, in all high dependency areas, if you see they will take a routinely ABG every fourth hourly, sometimes every 2 hourly, they will take a atrial blood sample to check whether pH is normal or not. What is pH? Basically, pH is power of hydrogen, power of H plus ion. So why it is necessary? Why we need to study so much about the ABG? If you see, I told you pH. pH is nothing but power of hydrogen ion. Power of hydrogen ion. H plus ion. That is a pH. Our like blood will be having normal pH of 7.34 to 7.43. That is our normal pH. It should be like our blood should be maintained this much pH, this much range only. If it is getting dearranged, if it's getting less than 7.34, if it is getting more than 7.43, what will happen? There will be altered pH. So why the pH is important? So basically, I'm telling to console you that why we need to study about pH, why we need to study about ABG. So that is what my question is. I'm asking you. So if you ask me why it is important means because if you see our whole body is running by the function, by physiological functions, digestion, respiration, your cardiac events, your mechanical events, circulation. Everything is a like event. All this event are happened done by the enzymes. If you see all even like cellular metabolism to organ function, everything is depends on the enzymes. All enzymes, okay, all enzymes will help in a cellular metabolism and organ function. Every physiological function has been run by the enzymes. If the enzymes wanted to work, if the enzyme is functioning means they need they need specific pH. I told you the enzymes works at a specific pH. That is what your normal pH is 7.34 to 7.43. This range only the enzymes will work properly. If this pH is getting altered, so there will be an enzyme dysfunction. So the enzymes will not work. Dysfunctions will be there. Dysfunction will be there. So enzymes will not work. If enzymes will not work, just I'm giving you an example. In what will happen in sepsis, in infection, what will happen? There will be altered pH. Means there will be a acidosis. There will be lactic acidosis. So what will happen? The enzymes stop to work. So if I'm giving an example, if liver enzymes are there, if your liver enzymes are not working, means your coagulation process will be disturbed. So the patient will exhibit the symptoms of bleeding tendency will be there. If you puncture anywhere, the vessel will not get coagulated, they will not repeat lactation because everything is done by the enzymes. If the pH is getting altered, the enzyme will not work. That's how the ABG is very important. We have to target the ABG, we have to target the pH. We have to keep the pH around 7.34 to 7.43. That is our main like basic demand. Why we need to study the ABG. That's why in ICUs, because in ICUs and all, if you see means infection is common. due to the infection only, due to the surgical site infection, due to the normal medical infection, due to the device related infection, the patient will be there in a ICU. So he's getting they are prone to go for acidosis or alkalosis. So that's why we are taking the ABG sample to check whether the pH is normal, whether the enzymes are working in a normal particular range or not. So that's what the importance of your arterial blood gas analysis. Now we'll move towards the topic. Now we got to know why this ABG is very important, very vital. Now, like before taking a ABG sample, before taking a arterial blood gas sample, what we have to do? We have to check the collateral circulation. To checking collateral circulation only, we are doing two tests. Okay, we are doing the two tests. Namely, first one will be Allen test, and so we are doing the Allen test to check the patency of the collateral circulation. What will happen if you're not doing a Allen test or modified Allen test? What will happen if you're puncturing the radial artery? If collateral circulation is not working, means your ulnar artery is not working. What will happen? There is vascular compromise. So the vessel will turn to that distal tissue will turn to necrosis. Hypoxic injury will be there. So to prevent that one only, we are checking the patency. We are checking the collateral circulation. If collateral circulation is working properly, then we'll take a sample and we'll run the sample. So that's why we have to perform the Allen test. In JIPMA skill test 2025, they asked regarding the Allen test. They given you a patient in a skill test, they given you a patient, they said to perform the Allen test. Before this one, Allen test this one is traditional one. Okay, this one is traditional one. Means nowadays we are not practicing Allen test. We are doing modified Allen test. This one is a traditional conventional. What will check in Allen test? We will check the collateral 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 circulation. We'll check the collateral circulation. Mainly which artery? Which artery will check collateral circulation? Your radial artery and ulnar artery. Both artery will check the patency. How we will perform the Allen test CPC means what we'll do, we'll tell the patient to make a fist. After that, what we'll do with the both thumbs, we'll compress here one ulnar I am also compressing, and I'm compressing the radial artery. Both I am compressing it. I'm telling the client to make a fist or a clenched hand. Okay, clenched palm. We are making the fist. Then we'll compressing the both artery, ulnar and radial artery. We'll compress this one for 30 seconds. What we'll do after 30 seconds? We'll leave the compression, and then we'll tell the patient to open the fist. Okay, once the like you get the palm like paleness, then we'll release the compression. Then we'll tell the patient to open the clinch. So after opening, what will happen? That whole pale area should be converting to the pink or redishness. So it indicates collateral circulation is there. Both your ulnar and radial artery patency is there. So it indicates collateral circulation working properly. So you can puncture the radial artery and you can take the sample. So there will not be any vascular compromise, because if you're blocking the radial artery, also your ulnar artery will be working properly. So perfusion will be maintained to your palm. So what I told here, the clenched palm is there. So here if you see means paleness is there. Once paleness will visible means we'll release the compression. After releasing compression, this whole will be turning. This palm will be turning to red or pink. That indicate collateral circulation is there. If it is not turning to pink or red, what will happen? It indicates there is a peripheral vascular disease. There is a vascular compromise. So that time what you have to do? We should not puncture the radial artery. Then we'll go for brachial artery or else femoral artery puncture for taking the ABG samples. And one more test we'll do. The second one is a modified Allen test. Okay, the second one will be a modified Allen test. Here I'll tell you the like steps to follow. For first, what I told, like make a fist, then compress the radial artery and ulnar artery. Then what we have to do, until the until the paleness, until the hand will turn to paleness, We have to compress after paleness. After you will see paleness, what you have to do? You have to release the compression. Have to release the compression. Then after releasing compression, what will happen? What will happen if the hand will turn? If the hand is turning to pink means positive allen test means if the ulnar artery is producing a adequate blood flow means we call that one as positive allen test. Positive allen test is normal means adequate collateral circulation is there that indicate adequate collateral circulation. So if negative allen test, if not negative allen test means there is inadequate blood flow. There is inadequate blood flow. That indicate there is inadequate blood flow. So that time we should not choose that radial artery. We should go for brachial artery. We should go for femoral artery. Positive and negative allen test. Positive allen test will be normal. Will be normal means there will be adequate blood flow. There will be a adequate blood flow. That finishes your Allen test. I told you modified Allen test, nothing but here what we'll check? We'll check the mainly ulnar artery. We'll check the mainly ulnar artery patency. We'll check the ulnar artery patency. Here what we'll do, very simple. It's very simple. What we'll do, just we'll compress the radial artery. We'll compress the radial artery. We compress the radial artery just for a 1 minute, just for a 1 minute or 60 seconds, we compress the radial artery. Then we'll see if any vascular compromise is there, any paleness is there. If paleness is there, means we call that one as negative modified allen test. Means there is inadequate blood flow from the ulnar artery. Ulnar artery is not patent. If there is no paleness, even after compressing 1 minute also, it indicates ulnar arteries circulation is adequate. There is adequate blood flow. That is positive modified allen test. Always keep in mind that modified allen test means we are talking about the ulnar artery patency. If allen test means we are talking about the collateral circulation means the radial artery and ulnar artery. So for taking a AB sample, you want to take a AB sample, like how are you going to select the site? I told you first and foremost priority is your radial artery. Okay, first we'll go for radial artery, then we'll go for brachial, then we'll go for femoral. If your radial artery circulation is not there, collateral circulation is not there, if there is negative allen test, if there is negative modified allen test, what we'll do, we'll further go for brachial artery. Okay. After that, what we'll do, like site of depth of insertion, how we're going to hold the needle, which needle you're going to use, which gauze needle you're going to use for taking the atrial blood sample. Usually we'll take the 22 to 20, 24 gauze needle. We'll take a 22 to 24 gauze needle will take and we'll prick a radial artery with the 45-degree angle for a radial artery. If you want to puncture the radial artery means you have to slightly bend the needle up to 45 degree. We should make the angle of 45 degree. Then you should prick the radial artery. If there is vascular compromise, if there is negative allen test, what we'll do? We'll go for a brachial artery. Brachial artery usually will be larger in size. So 60-degree angle we can insert the needle. And if you pricking the femoral artery, you should make a 90 degree. You should make a perpendicular angle. Then you can puncture the femoral artery and then you can take the sample. I'll tell the like basic procedure. What and all we needed like for taking a sample, for taking a AV sample, you should require a heparinized syringe. Okay, you should require heparinized syringe. What will happen if you're not using heparinized syringe means the blood sample will clot. That's why we should make a heparinized syringe of 2 ml. Okay, 2 ml heparinized syringe we should take, and plus I told you 24, usually 24 gauge needle you can take. Needle selection also based on femoral artery. Femoral artery is there means you can use a lengthier needle, like 22 ml you can use. Usually, like ideally 24 will take 24 gauge will need to take, and then we'll choose a selection of site. Radial artery means we'll take a sample with a 45-degree angle. Then we'll send the sample with the ice container, ice lined container. We'll send the sample to lab and we'll get the ABC reports. It will get reports. Now, okay, before starting anything, we should put a foundation. Okay, we start from the foundation. That is your basics of ABC. You should know. You must and should know the basics, because if you're not knowing the basics, means there is no use of learning the compensated, uncompensated ABCs and all. So validating ABC, interpreting the ABC, analyzing the ABC, you should require some basic knowledge. Okay, some sound basic knowledge. Okay, not only basic knowledge, you should require the sound, thorough, crystal clear topic of the basics of the ABG. If you're studying in a study room and all, if you're studying in a like in your room, means you should keep a like a paper, white paper, write it the normal ABG values like pH, PCO2, what is PO2, how much will be bicarbonate level, what is anion gap, that all should be written on a white paper with a highlighter. You should keep in a where you can like repeatedly your eyes will go there, you can paste that one, and it should always go for check with the normal basics ABG parameters. Then only you can able to like predict what kind of ABG it is, whether it's normal ABG or abnormal ABG. Because you should know normal, then only you can identify the abnormal ABGs. So basics I told you 7.34 to 7.43 is a normal blood pH. Okay, this one is normal blood pH. That is 7.34 to 7.43. That is your normal blood pH. Everything normal, every normal will study here. What is next will be what is your normal PO2 level? Like if you see PO2 is nothing but partial pressure of oxygen inside the plasma. If you see oxygen will travel in a two part. Okay, we'll choose a two area to travel to the tissue. From one from okay hemoglobin bound. Okay, oxygen what will do? Oxygen will bind to hemoglobin molecule which is present in your RBC. Then it will travel to tissue. And one more route will be one more transportation route will be your plasma. What will happen in your blood? There will be a plasma. There will be a plasma. So what will happen? The O2 will dissolve in a plasma. Will dissolve in a plasma, and it will travel to distant tissue or distant organs. So here in ABG, what we are doing, we are checking the dissolved. We are checking here dissolved. We are checking here dissolved O2 content. O2 content in a plasma. That's why I'm calling this one as partial. It is not full. It is a partial concentration of partial PaO2. Okay, we call that one as PaO2. PaO2 is nothing but partial atrial oxygen content. Dissolved O2 in a plasma. So this should be normal around 80 to 100 percentage. It should be normal of 80 to 100 percentage. If patient is on ventilator, okay, patient is on ventilator. If patient is on ventilator, intubated on ventilator, means if you see a target PO2 level, target PO2 level will be target PO2 level will be five times of FiO2, five times of FiO2. So if I'll give example, if FiO2 they kept around 40. So your normal targeted PO2 will be 200. So that's what your normal PO2 level. So five times of FiO2 should be there. That is your normal PO2 levels. And we are talking about the basics of ABG. That is okay. We talked about we got to know what is normal pH 7.34 to 7.43, and what is normal PO2 level, normal dissolved O2 content in a plasma, that is 80 to 100 percentage. Now third parameter will be PaCO2. PaCO2 is nothing but partial pressure of partial atrial CO2 level, carbon dioxide level. That will be around 35 to 45 mm of Hg. 45 mm of Hg. 35 to 45 mm of Hg. That is a normal PaCO2 level, partial pressure of carbon dioxide level. And one more thing, that is your bicarbonate level. Normal bicarbonate will be 21 to 28 milli equivalent per liter. That is what your normal like major. I'm taking here only the major normal ABG parameters. If you want like somewhat extra means I will write here somewhat extra normal ABG parameters. That is your anion gap. Okay, that is your anion gap. Just keep in mind that just now like for a basic, just keep in mind that anion gap. I will in the last series of session I'll tell you the what you mean by actually the anion gap. Fifth one will be an ion gap. An ion gap. That will be 6 to 12 milli equivalents per liter will be a normal. Just now as like keep in mind that anion gap will be around 6 to 12 milli equivalents per liter. And one more is there BE. What do you mean by BE? BE nothing but base excess. Base excess. That will be normal of -2 to +2. Okay, -2 to +2 is the normal base excess. If it is getting altered means we'll get the acidosis or alkalosis. This is what your normal ABG parameters look like. It will give, okay, if you see the ABG report, it will be having the electrolytes. So your sodium will be there, your potassium will be there, and it will be containing chloride levels, and it will be containing the SO2 level. What do you mean by SO2? SO2. SO2 means saturation of oxygen means hemoglobin bound oxygen level. Normally, if it is arterial sample, that should be around 90 to 100 percentage. If it is arterial sample, if it is venous sample, that will be around 60 to 80 percentage. That's what your SO2 levels. That's what your like normal basics of basic ABG parameters looks like. I told you to summarize. Normal pH of blood will be 7.34 to 7.43, and second parameter is PaO2 means dissolved O2, that will be 80 to 100 percentage, and PaCO2 will be 35 to 45 of Hg. And fourth one will be bicarbonate level, SCO2 level. That will be 21 to 28 milliequivalents per liter. Now we will see regulation, how the H plus ion, how the hydrogen ion is getting regulated. That is by the buffer system. If you see, like you taken the ABG, if taken the ABG of the patient, you will see that ABG report. In the ABG report, there is a 7.15 is a pH. Means now what happened? pH is came down means pH is come down means there is an acidosis. There is an acidosis. So if there is acidosis, nothing but there is more H plus ion. There is more H plus ion. So there is a variation in H plus ion means how our body is going to regulate that H plus ion. We'll see in that. Our first line of defense. Okay, first line of defense again is the acidosis alkalosis will be your buffer system. Okay, will be your buffer system. If there is any alteration in pH, your buffer system is the first and foremost is organ or like system to act. Buffer system. Buffer system is a first line and foremost. Like if there is any, like if you see any ABG changes are there, like within a 2 to 5 second, this buffer system will be activated, and it will try to compensate. It will try to maintain the normal blood pH. First line of defense. Second line, if you see, means lungs is the second organ to response. Okay, second organ to respond for the change in a blood pH. It will take around 20 minutes to compensate. Third line will be your kidneys. Okay, your kidney is the third most organ to respond for the pH change. Okay, pH alteration. It will take around hours to days. It will take around, not approximately, we don't know. Like that's why I'm telling you, from hours to days it will take. But if you see kidney will do a definitive compensation. It will make a definitive compensation for change in, okay, alteration in a ABG parameter. Definitive compensation mechanism it will do. So one by one we'll see like all this defense system when there is alteration in pH, when there is altered pH. So how our body naturally try to defend that pH, okay, try to compensate, try to overcome, try to normalize the blood pH. Now, first and I told you, first and foremost, like system is to like get into action is that is our buffer system. It will take seconds to act. Second will be your lungs. Lungs try to compensate for change in pH. It will take around minutes, okay, 20 to 30 minutes will take. Third line will be like definitive compensation mechanism will be done by, okay, ultimate compensation done by your kidney. First, we'll see buffer system. In buffer system, like primary health care worker, I made a mnemonic called as PHCP. Okay, PHCP nothing but primary healthcare provider. So how this buffer, okay, what are the different components present in our buffer system? Buffer system means maintaining a balance, maintaining the normal range. That's what we call as buffer. Okay, in English, if you just understand the English means you will get to know the concept clear. That's why I'm telling you, okay, first clear with the English. The English will going to like cause you the like change in your answering and all. So buffer system that contains P for phosphate. P for phosphate. P for phosphate. Phosphate is an it is an ion. Okay, it is an ion present inside the cell. Okay, it will be present inside the if this one is a cell like inside the cell there will be a phosphate. What will happen if there is acidosis? If there is more H plus ion, what will happen? The H plus ion will move inside the cell and the PO2. Okay, the phosphate will come in outside the cell. This is how the phosphate is going to compensate when there is acidosis. It will go out and it will push the H plus ion to inside the cell. That's how the phosphate will work in this manner. Second one will be your H. H means hemoglobin. Hemoglobin, what will do? Whatever hemoglobin will do same if this one is a hemoglobin molecule, if there is acidosis, what will happen? If there is acidosis, it will take the H plus ion and it will gain bind on the it will get bind on the surface of the hemoglobin. If there is acidosis, if there is an alkalosis, if there is alkalosis, nothing but if there is less H plus ion, okay, if there is less H plus ion, it will start to release the H plus ion from the surface. That's how it's going to buffer, means it will maintain the neutrality. It's trying to maintain the balance between the balance of H plus ion. And third one will be your carbonic acid. Carbonic acid. Carbonic acid it will do some reaction. Okay, carbonic acid means H2CO3. What will happen if there is an alkalosis? What will happen? It will release the H plus ion and along with the along with the bicarbonate ion. H2CO3 minus. So there will be an increased amount of H plus ion, though it will cause the acidosis. That's how the carbonic acid is going to act, and it's going to maintain that electrical neutrality, pH neutrality. And the fourth one will be your plasma proteins. Your plasma proteins. Your albumin is there. Normally plasma protein nothing but we are having albumin, globulin and fibrinogen. So if you see albumin it's a colloid. It's a colloid nothing but it's a larger compound. It's a larger molecule. What will happen if there is acidosis? The albumin will try to attract the H plus ion. If this one is albumin is going to attract the H plus ion. So on surface of the albumin, the H plus ion is going to bind. So it will dissolve into the albumin. So that's how the plasma proteins will help to maintain the neutrality, neutral pH. Now moving to second defense mechanism. Or what is second mechanism? Defense mechanism will be lungs. Let's see how the lungs is going to respond for your changes, alteration in the pH levels. I told you if acidosis means pH is getting down. Okay, pH is came down less than how much? Less than 7.34 it is coming, means we call that one as acidosis. If pH is okay, if pH is getting increased, more than 7.43, what we'll call it? We call that one as alkalosis. Okay, alkalosis and acidosis. Now we'll see how the lungs is going to act and it will going to compensate on a acidosis. Means pH is getting down, pH is decreasing less than 7.34. That time how the lungs will respond. Now normally lungs is there here. Here we are having the lungs. What is happened now? pH is coming down and H plus ions are increasing and H plus ions are increasing. What it will do? It will do like excretion. It will increase the excretion of CO2. How? How to increase? By increasing the respiratory rate. By increasing the respiratory rate and increasing the CO2 washout by increasing the depth of respiration. Increasing the depth of respiration. By the two mechanism, it's going to wash out. It's going to wash out the going to wash out the going to wash out the CO2. I told you how by increasing the respiratory rate and by increasing the depth of inspiration. We can excrete the carbon dioxide. If you are excreting the carbon dioxide more, what will happen? The carbon dioxide will bind with the H plus ion. Okay, it will bind with the H plus ion and it will make a H2CO3. So it will cause HCO3 plus CO2 release. So CO2 release means CO2 excretion will be more. So if you see basically the CO2 is volatile. Okay, CO2 is volatile gas. So it will make the if it is CO2 is there means what will happen? There is a formation of carbonic acid. There will be formation of carbonic acid. Carbonic acid nothing but more H plus ion. Okay, more H plus ion. So if you washing out, okay, if you washing out the CO2, so there will not be a acidosis. In case of acidosis, what will happen if you see patient is on like will where will be pH is coming down, that patient will be having more respiratory rate. If you see that patient, okay, they will be compensating by respiratory route, by the respiratory rate. Okay, they will increase their respiratory rate to wash out the CO2 because CO2 is a volatile gas. It will make the pH acidotic by the formatting of carbonic acid. Increasing the rate will be there. Increased depth of respiration will be there in case of acidosis. By this how the lungs will compensate for the altered in pH. And if you see, okay, completely like compensated ABG values of respiratory acidosis, the PaCO2 level will be less than 30 to 35 mmHg. That is an indicator of compensation. That is an indicator of compensation. Compensation indicator. How are we going to know? Okay, how are we going to know if our lungs is getting responding? Our lungs is getting compensate. Our lungs is responding. Our lungs is compensating for acidosis. We'll take a ABG and then we'll see PCO2 level. If PCO2 level is less than 35, it indicating that lungs is working. Lungs is getting compensating for the change in pH for acidosis. Next, we'll see like how the lungs is going to respond for the alkalosis. Here, what will happen? Here what it will do? There will be an increased retention. Now our target is to increase the PCO2 level. How much more than 45 mmHg? I told you CO2 is an acid gas. Okay, it is an acidotic. It's acidotic. So how it's acidotic? It will form the carbonic acid. It will form the carbonic acid. Acid here name is supposed acid means H plus ion. Okay, more H plus ion. How it will make acidosis? I told you last like, chemical reaction. It will form and then it will form the carbonic acid. So what is there now? pH is alkalosis is there. Now alkalosis is there means pH is more. Now pH is more. Now our target is to reduce the pH. Okay. Here I told you pH is now more. More pH means less H plus ion, less H plus ion. So now our target is to make the more acid. Now our target is to make the more bicarbonic acid. Bicarbonic acid. No, sorry, not only carbonic acid. Now our target is to make the more carbonic acid. So there will be increased H plus ion. How we are going to do? We're going to increase the PCO2 level. How we are going to increase the PCO2 PCO2 level by reducing the respiratory rate. By the reducing the respiratory rate. Respiratory rate we want to come down means we want CO2 retention. We want CO2 to be retained inside the lungs. So how we want to make the CO2 retention means we'll reduce the respiratory rate. So there will be hypoventilation. There will be a hypoventilation, and there will be a reduced depth. Patient, if you see alkalotic patient will be having shallow breathing, means there will not be a deep breathing. Deep breath will not be there. Sorry, deep breath will be coming down, or we can say shallow. Okay, we can say shallow, not swallow, shallow. Shallow breathing will be there. If you see breathing pattern of a alkalotic patient, he will be having shallow breathing. Okay, shallow breathing. Now we like third line of defense, third line of compensatory mechanism. It is which is very like definitive management of your acidosis. Final, but very vital in case of compensating the acidosis and alkalosis. Kidney is an definitive system. Okay, definitive, it will do definitive, and most most effective most effective compensatory system in a body. Compensatory system in a body. So we'll see how kidney is going to regulate the H plus ion. What will happen in case of So I told you kidney is the ultimate responder of acidosis or alkalosis. So how it's going to regulate means it's going to act on the mainly like tubules, renal tubules is there. Now they're going to act a role in case of acidosis. In case of acidosis, I told you acidosis there will be more H plus ion. There will be more in acidosis more H plus ion, and pH is less, is less. So what will happen? The kidney from the tubules start to release the H plus ion. So there will be a excretion. There will be a excretion, more excretion of H plus ion from the from the renal tubule, from the renal tubule. So by this mechanism, our body is losing more amount of H plus ion means there will be a correction of acidosis. In case of alkalosis, what will happen? There will be less. Okay, here acidosis more H plus ion. In case of alkalosis, there will be less H plus ion means pH is more now. Now pH is more. So what will happen? Our body will try to retain. Okay, our kidney tubules will try to retain the will try to retain the will try to retain the H plus ion from the reabsorption. They will do reabsorption of H plus ion from the tubules, from the renal tubules. If there is retention of H plus ion means there will be increased pH. There will be increased pH means there will be normal H plus ions. That's how your kidney is going to regulate. Means when there is acidosis, it will try to wash out. It will try to excrete more H plus ion from the renal tubules. If there is alkalosis, it will try to retain. It will try to absorb the H plus ion from the renal tubules. Okay, that's how the kidney is going to work in case of acidosis or alkalosis. That's how it's going to regulate the regulate the normal blood pH. Now we'll see normal ABG report, which has taken from a which are taken from the ABG like patient. Here is your ABG report. It's how like your ABG report will see if you worked in a ICU, if you worked in a emergency and all means you would like seeing this ABG report. If you zoom and see means it will be having pH. I told you pH normal pH is 7.34 to 7.43. Now we'll see like normal how the normal ABG parameter ABG will look like. I told you pH here is we are having pH of 7.40. So pH is now normal, and I told you we'll see PCO2 level. PCO2 level I told you 35 to 45 mm of Hg. Here if you see means here it is in ABG report, in this ABG report it is 41, means it is normal. pH also normal. And if you see third parameter will be is PO2 level. PO2 I told you 80 to 100 is a normal. Here if you see 104 is there. 104 is also normal. 104 is normal. And you can see bicarbonate level. Bicarbonate is 25 here. HCO3. Normal I told you 21 to 28 milliequivalents per liter. Here in this ABG given ABG report it is 25 milliequivalents per liter. So it is normal. I told you normal ABG. Okay, if you take a ABG, it will show you the electrolyte also. Normal sodium level 135 to 145 milliequivalents per liter. So it is here if you see means sodium is the given in millimoles. Okay, millimoles. 124 the given. So there is hyponatremia. Here there is hyponatremia is there. And you can see chloride also. Chloride is normally, it will be normal 109 to 110 milliequivalents per liter, millimoles per liter will be there. So here if you see means 1 how much they given? 95 they given. Okay, 95. So there is hypochloremia. Here in this ABCs, electrolyte abnormality is there. Electrolyte abnormality is there. Means sodium is reduced 10, that one is 124. Your chloride is 95. Hypochloridemia is there. Means both sodium and chloride levels are came down. So there is more sodium and water loss is there. And if you see like ionized calcium also will be there. Ionized calcium also will be there. This should be 0.3 to 1.5. That is your normal see like ionized calcium level. Ionized means which is bound to albumin. And if you see it will be having hematocrit will be there. Hematocrit is there. HT means hematocrit, and it's having an ion gap. I told you an ion gap will be 6 to 12 milliequivalents per liter. And you can see SO2 is also is there here. If you see clearly, hematocrit, anion gap, and PO2 and SO2. This ABG is not having SO2. Normally, we will be having the SaO2 level in a ABG parameter. That's how your ABG, normal ABG report will looks like. Now we'll see like we'll move forward. Further, we'll move forward like good indicator of respiration. Good indicator of a respiratory disorder will be I told you PaO2. Sorry, PaCO2 is a good indicator. In exams, if they ask you, okay, what is a like sensitive, more sensitive or good indicator of respiratory disorder will be PaCO2, means partial atrial CO2, carbon dioxide content. And more sensitive or good indicator of metabolic disorder will be always bicarbonate. Always bicarbonate is a this one is a good indicator of metabolic disorders. Now we'll validate the ABG. We'll validate the ABG and we'll interpret the ABG and we'll analyze the ABG in a single note. There is a term called as a ROM. What do you mean by ROM? ROM is nothing but a respiratory opposite. Okay, I'm writing here respiratory opposite. I'm writing here on the top. Respiratory will be always opposite. Will be always opposite. A respiratory opposite and metabolic equal. What does it actually means? Respiratory opposite means if like pH and PaCO2 will be always inversely proportional. Always inversely proportional means if there is increased PCO2, there will be a decreased pH. If there is increased pH, there will be a there will be a will be reduced PCO2 level. So that's how there is a link. Means when there is pH is coming down, when the pH is low, your PCO2 will be always higher side. I told you PCO2 is a volatile gas. Okay, volatile carbonic acid. It's gas. It's an acid, carbonic acid. So always if there is PCO2 rise, it means there will be a acidosis. Acidosis means what? Reduced pH. That's how the respiratory is opposite. And one more term is there, that is metabolic equal. Metabolic equal, almost all equal. How it is equal? How it is equal means pH. Your pH and bicarbonate is directly related. They are directly related. Means if your pH is more, your bicarbonate will be more. If there is alkalosis, if I am telling alkalosis, there is increased pH. And same way there is increase in bicarbonate level also. That's how we are validating the ABC. If you see in ABC, if there is reduced pH and there is increased PCO2, that means we call that one as a respiratory acidosis. Okay, by the basic concept, if you are remembering the term called as Rome, you can able to validate, you can able to interpret, you can able to give a name, you can able to diagnose which kind of abnormality it is in. So always be clear that what you mean by Rome. Rome is respiratory opposite and metabolic equal. Respiratory two terminologies here. Okay, two disorder and two terminology. Respiratory opposite, metabolic equal. Means if pH is normal, if bicarbonate is normal means it's normal. pH is getting more, okay, pH is increased, and your bicarbonate is getting increased, means we call that one as metabolic alkalosis. Okay, now we'll see the concept of, okay, I'm taking like escalating the topic to like higher levels. Now we'll see what you mean by uncompensated and what you mean by compensated respiratory acidosis, what do you mean by partially compensated. These three terminologies are very important. Nowadays they are asking you regarding not only just normal simple ABGs, they are giving you, okay, they are giving you advanced ABG levels, and they are asking you the like validate the ABG and interpret the ABGs. They are asking you this one only. So you have to be clear with the concept called as compensated, uncompensated, and partially uncompensated ABGs. I taken you, okay, three ABCs. Okay, let me tell you. Okay, four ABCs in this sample I'm taken. Now we'll validate the ABC one by one. Okay, one by one we'll validate the ABC. First we'll go to normal. Okay, normal blood pH will be 7. I told you it should be always clear. It should be on your tongue, tip of the tongue. Normal ABC pH will be 7.34 to 7.43. Normal PCO2 level will be 35 to 45 mmHg. Normal bicarbonate level will be 21 to 28 milliequivalents per liter. This one is your normal ABG. We can say normal ABG report. This one is a normal ABG report. Now we will see first your second example. Here what happened? Here your pH is abnormal. Okay, your pH is getting altered. pH is abnormal. And your PCO2 is also abnormal. And bicarbonate is also abnormal. All three are abnormal. Okay, I'll give you an example. If your pH is 7.15 and your PCO2 is 55 mm of Hg, and your bicarbonate is around 29 milliequivalents per liter. Okay, means all are altered. Okay, all are abnormal. It is an partially, okay, this ABG and partially compensated. This is an partially compensated ABG. We can say this one is partially compensated means your pH is altered, your PCO2 is altered, your bicarbonate is altered. Means your body is trying to, here if you see, I told you pH is now pH is less, means patient is having acidosis. How it is having acidosis? Due to respiratory opposite. I told you respiratory opposite means your body, okay, your body is retaining more amount of CO2. So there is increased pH. pH increased and pH is reducing and PCO2 is reducing. Now patient is having respiratory acidosis. For respiratory acidosis, your kidney is trying, okay, your kidney is trying to compensate by the retaining by retaining like your bicarbonate ion. So if you see this one, okay, your normal, I told normal it will be around 28 milliequivalents. It is now it is increased to 29. Now it is increased to 29. Means this one also is trying to compensate. Kidney is trying to compensate. That's but it is not fully compensated. But it is not able to take the ABG pH to normal levels. That's why I'm calling this one as partially compensated ABG. Means your kidney is trying to compensate. How it's compensating? By increasing the bicarbonate levels, but your ABG is abnormal only. So it's indicating that, clear picture is indicating that there is partial compensation. There is partial compensation of ABG. Now we'll move towards the like next ABG example. So if you see second ABG, third ABG. Now like in last ABG everything is abnormal. That's why I'm calling that one as like uncompensated, partially compensated ABG. Means your kidney is trying to compensate. But if pH is not if it's not abnormal means, now we'll see third ABG. Third ABG will validate. I'll give an parameters. I'll give an parameters. Now we'll try to validate how what kind of pH this one is. Now pH is 7.32 and your PCO2 and if you see 7.32, that one is your pH, and I'm giving you value of PCO2 is of 40, 49, okay, 49 mmHg, and bicarbonate is 20 milliequivalents per liter. If you see, if you try to validate the parameters, pH is now normal, pH is normal, 7.34 to 7.43, pH is normal, and if you see PCO2 is getting increased. Okay, normal is 45, so it's abnormal. So I can say PCO2 is abnormal, PaCO2. PCO2 is nothing but PaCO2. Okay, PaCO2 is abnormal means your PaCO2 is abnormal. And if you see bicarbonate is normal, I told you 21 to 28. So it is also, this one is also abnormal. Your bicarbonate is also abnormal. So here is what happened. Two parameters are normal, but abnormal, but your pH is normal. So fully compensated. Now we can say this parameter, this ABG parameter as fully compensated. Ultimately, I'm telling you, ultimately, if pH is normal, that is fully compensating. It is stating that fully compensated. It is fully compensated. This ABG parameter is fully compensated ABG. Okay, fully compensated ABG. Nothing but fully compensated. Here, what is abnormal? Like pH. I told you pH is more, and sorry, your PCO2 is more, and your pH is almost like normal only. So that's why I'm calling this one as fully compensated. Okay, fully compensated respiratory acidosis. Okay, respiratory acidosis. And now third ABG, I'll give you an example of third ABG. If you see pH is of around, so fourth ABG parameter if you say means your pH is 7.15, and PCO2 will be around 55 mm of Hg, and if you see bicarbonate will be around 38 milliequivalents per liter. Sorry, your bicarbonate, you'll just keep a normal bicarbonate level of 22 milliequivalents is there. Now what is happening? Your pH is abnormal. So your pH is abnormal and PCO2 is increased now. PCO2 is increased means PaCO2 is increased now. So it is abnormal. And if you see your kidney is trying to normalize the bicarbonate level. It is normal. 22 is normal ABG. What is happening now here there is a what is happening now here there is an acidosis. Respiratory acidosis there. Okay, respiratory acidosis is there. For respiratory acidosis, what will happen? What will happen? Your kidney should work. Your kidney should work, and it start to retain the like bicarbonate level. There should be increased bicarbonate level. There should be increased to 38 or 30, 39, 40 and all. But kidney is not compensating here. Kidney is not compensating. It's not retaining the bicarbonate. It's not excreting the H plus ion. So I am calling this one as uncompensated ABG. This one as uncompensated ABG. So here what is happening? I can say this one is uncompensated respiratory acidosis. Respiratory acidosis. That's how the ABG like we can able to differentiate from uncompensated ABG, compensated, partial and compensated. Okay, this is what the difference is. Now we'll move toward the like, compensation rate. I'm telling you now, this time, like I'm telling you, like first difference will be your buffers, second system will be your lungs, third system will be your kidneys. Now we'll see like how the compensation rate will be there. Like in case of acute injuries, in case of chronic kidney disease, acute kidney injury and chronic kidney injuries, what will happen if there is increased PaCO2 level of 10 mmHg. Okay, above the more than if there is more than 45 mmHg, above that 445 mmHg, if there is further increase in 10 mmHg of PaCO2, they will be increasing. Okay, the kidney will try to increase, try to absorb. Okay, try to reabsorb the bicarbonate level. Okay, it will try to reabsorb the bicarbonate level of one. Okay, one milliequivalence will be 1 milliequivalent per liter will be increase in your blood. Okay, it will reabsorb the bicarbonate level more than a 1 milliequivalence per liter. If there is chronic, okay, if there is chronic compensation, if there is chronic compensation more than a mmHg increase in PaCO2 level, there will be increasing of 4 milliequivalents liter of bicarbonate. Okay, bicarbonates levels. That's how the composition rate will be there. Means if there is PO2 of there is PO2 of 40 mmHg, sorry, 50 mmHg, 50 mmHg. Here what happened? There is increased, okay, more than 10 mmHg. PaCO2 is increased. Now, if you see ABG, in ABG, your bicarbonate will be around 29. It will be around 29 in case of acute kidney injuries. In case of chronic case, okay, in case of chronic kidney disease, you can see ABG of 30, okay, 32 bicarbonate levels, okay, 32 milliequivalents bicarbonate level can be seen in a ABG report. It's a normal compensated, okay, expected PCO2 level, okay, expected bicarbonate level in a kidney injuries, okay, in a compensated mechanisms. Now we'll see expected PCO2 level, okay, expected PaCO2 level, expected bicarbonate level. There is a formula, Winter's formula. Okay, there is a formula called as compensation. I'm talking about compensation formulas. If there is any injury to kidney, how the lungs will respond. If there is damage to kidney, then how your lungs will getting to take an action. There is a formula called as Winter's formula. Okay, in examination they may ask you what is the Winter's formula. The Windows formula nothing but it will be like I told you like expected for this one is used for checking the expected PCO2 level. Expected PaCO2 level is equal to 1.5 into serum bicarbonate level, close the bracket, plus 8 plus or minus 2. Okay, that's what your PaCO2 level. PaCO2 level. I told you this works in case of only when there is metabolic problem, when there is kidney injury. How you going to like lungs is going to retain the how much your lung is going to retain the CO2 level. So if I told you, okay, if I told you if pH is 7.83 means more pH, okay, more pH means it's an alkalotic situation. It's an alkalotic situation. So how your lungs is going to respond? How your lungs is going to compensate for this altered pH? So I told you in this patient, okay, if your lungs is getting working properly, your normal expected PaCO2 level should be around, if they given you pH of 7.83 and they given you bicarbonate level of 28. Now we'll see, okay, 1.1.5 into, I told you serum bicarbonate they given 28, and if you add plus 8 and plus 2, if you add means we'll get the value of 1.5. If you see, it will be around, if we calculate and all, if you see means we'll get the value of, we'll get the value of we get the value of 52. Okay, 52 will get the value of 52. If you clearly do some mathematics means we get the expected PCO2 of 52 or 50. We can get 50 or 52. That is your normal expected PCO2 level. That's we'll get through the Winter's formula. If your lungs is working properly to compensate for the acidosis or alkalosis, that is how we can see the expected PCO2 level. That finishes your basics of ABG. Now in this next video note, part 2 video note, we want to see how the respiratory acidosis, what do you mean by respiratory alkalosis, what do you mean by metabolic alkalosis, what do you mean by metabolic acidosis. This four concepts are dealt in a second video note, part 2 video note. This is finishes your part 1 video. Thank you for watching it. Hi, welcome you all for KNO classes. This is the part 2 video of ABG series. In part 1, we talked about ABG interpretation, ABD validation. Now let's see what we mean by respiratory acidosis and what we mean by respiratory alkalosis. What is the differentiating points? What is the pathology and what is the differentiating point behind the acidosis and alkalosis? Now, in respiratory acidosis, if you see, I told you pH will be less than 7.34, and your PaCO2 will be more than 45 mmHg. When there is more retention of PCO2, there will be a condition called as acidosis. If you ask me what are the condition that will cause a respiratory acidosis means, there is a mnemonic called as depress. Depress means D for depressants. Depressants means CNS depressant. If you're giving the drugs called as CNS depressant, like morphine, if you're giving the morphine, or if you're giving the propofol, if you're giving the metazolone, if you're giving the fentanyl, what will happen is will suppress your CNS. So there'll be a central nervous system will be suppressed. So there'll be a hypoventilation. Hypoventilation means the person will be having more CO2 retention. More CO2 retention means more bicarbonic acid. Acid means there will be more explosion. So there will be a reduced pH level. So it's going to cause respiratory acidosis. I'm talking about the condition that will cause a respiratory acidosis. E for embolism. Embolism nothing but pulmonary embolism. What will happen in pulmonary embolism if the patient is having deep vein thrombosis or any vascular thrombosis, that will dislodge and go to right atrium, then right ventricle, then it will go to pulmonary tree, then it will obstruct the pulmonary artery. So there will not be a ventilation perfusion. So there will be a reduced rate of respiration. So that is going to cause CO2 retention. So that's going to ultimately cause respiratory acidosis. And one more, depress. Depress means P for pulmonary edema. P for pulmonary edema, nothing but ARDS, nothing but ARDS. What do you mean by ARDS? Acute respiratory distress disorders. Means in case of pneumonia, in case of pulmonary contusion, in case of lung trauma to chest, what will happen? There will be an increased more amount of fluid inside the lungs. In case of cardiogenic pulmonary edema and all of this means the lungs will be filled with more water. So ventilation perfusion will not happen. There will be a shallow breathing. So it will cause again a PCO2 retention. So keep in mind that what are the conditions that will cause hypoventilation, that will cause a reduced respiratory rate, and that will cause a reduced depth of respiration. So that will ultimately increase the retention of CO2. Retention of CO2, nothing but more acid. Okay, respiratory acidosis will be there. So I'm taken here the mnemonic called as like R depress. R depress. Depress means R means like respiratory conditions. Respiratory conditions like your PC, your COPD. COPD, what will happen? There is outlet obstruction, chronic obstruction for the ventilation. So we are in and out. Your inspiration and expiration is happening, not happening properly. So there is no free flow of expiration. So there will be a retention of PCO2. If you see like condition like emphysema, atelectasis, bronchiectasis and all, that condition there will be an outflow obstruction. There will be a more retention of the PCO2 level, PaCO2 level. So that will cause a respiratory acidosis. Again, E for the depress. Again, E for the empyema. Empyema means pus in the pleural cavity. That is also going to cause the respiratory compromise and will cause the PCO2 retention. As is in case of severe burns. Severe burns is going to cause the respiratory retention. So this all other condition they will cause increased PCO2 retention and will cause ultimately respiratory acidosis. So if you see in the patient on examination, okay, on examination, if you see patient will be having reduced rate of respiration, hypoventilation will be there. There will be hypoventilation and there will be a reduced depth, okay, reduced depth of respiration. There will be reduced depth of respiration. That all are the features of your respiratory acidosis. Now we'll move towards the now we'll see what are the difference between acidosis to alkalosis. I told you in case of acidosis there is a reduced pH. If in case of alkalosis there will be a increased pH. There will be more pH and reduced reduced PCO2 PaCO2 level. I told you Rome is always respiratory is opposite. Respiratory is opposite. Here pH will be more than 7.43. Okay, 7.44 and your PaCO2 level will be less than 35 mm of He. And if you see patient will be having hyperventilation. Okay, patient will be having hyperventilation, more respiratory rate. Tachypnea will be there, and more increased depth of respiration will be there in case of alkalosis. Here, what is happening actually, what is the pathophysiology behind the respiratory alkalosis? There is PaCO2 washout. Okay, carbon dioxide washout. There is carbon dioxide washout is there. That's why there is loss of acid. There is loss of carbonic acid through carbon dioxide route. So it is causing a respiratory alkalosis. Now we'll see what are the conditions that will cause a CO2 washout and ultimately will lead to respiratory alkalosis. Like now fever, if you see fever is I mean patient will be having more respiratory rate, fever and anxiety. If patient is anxious, there will be increased respiratory rate and one more thing. Okay, you can see if the patient is having taken any CNS stimulant. Okay, any CNS stimulant drugs is taken means they will be having a more respiratory rate. This and all the condition like if there is increased rate of respiration, increased work of breathing is there means that all will cause the CO2 washout. So it is going to ultimately cause a respiratory alkalosis. Both are dangerous only, but if you see compare and see means your respiratory acidosis is too much dangerous disease condition. Now we'll move towards the metabolic component, metabolic acidosis and metabolic alkalosis. Two terminologies are there here. Clearly, like understand that one: metabolic acidosis and metabolic alkalosis. here what is happening? I told you here what is happening in acidosis. Always pH is coming down. pH is reduced here. pH is getting reduced here. We'll see here pH is will be less than 7.34, and your bicarbonate level level will be, this is also will be less than 20 to 21 milliequivalents per liter. So that is going to cause the metabolic acidosis. I told you Me means metabolic equal. Always metabolic will be equal. And if you see condition, so condition if you ask me means CKD in case of kidney disease. Okay, in case of CKD or AKI, what will happen in case of CKD and AKI? The kidney will not able to produce the aldosterone. So aldosterone if you see means hypoaldosterone, nothing but in case of CKD there will be a hypoaldosteronism. Okay, hypoaldosteronism. What will happen in case of hypoaldosteronism? Kidney is not able to produce the aldosterone. What is the function of aldosterone? It is going to retain the sodium chloride and excrete the H plus ion and excretion of H plus ion and potassium. In case of CKD, what will happen? The kidney is not able to produce the aldosterone. So there will be excretion of H plus ion, and there will be a retention of there will be retention of the there will be retention of. So what will happen? Your aldosterone will not be produced in a sufficient quantity. So there will be excretion of sodium water, and there will be a retention of H plus and potassium ion. So there will be a acidosis and hyperkalemia in case of CKD and AKI. If you see CKD patient, they will be having always hyperkalemia. That's why we'll give sodium polystyrene. That's why we'll give potassium binders. That will give a insulin with a 25% dextrose. That is all the correction method we can do in a hyperkalemia. But in acidosis, we have to alkalinize the patient. So that one is a condition AKI and CKD. Insufficient amount of aldosterone is produced in case of AKI. And one more thing, like aspirin toxicity. In case of aspirin is an acid, okay, salicylic acid. Aspirin toxicity also you can see metabolic acidosis. And in case of DKE, what do you mean by DKE? Diabetic ketoacidosis also can able to see the metabolic acidosis. And your various renal parenchymal disease, okay, various renal parenchymal disease also you can able to, means renal tubular acidosis will be there. Okay, various renal parenchymal disorder also you can able to see the metabolic acidosis. And one more thing, next condition called as metabolic alkalosis. What do you mean by metabolic alkalosis? Here what is happening? Your pH is more than a 7.43, and your bicarbonate level, if you see, means that will be more than 28 milliequivalents per liter. So I told you respiratory opposite and metabolic equal. If you see like autonomic condition, there is more washout of acid, more washout of bicarbonate level, no more retention of bicarbonate level, but there is more amount of H plus ion loss is meant. We call that one condition as alkalosis. In which condition you will see more H plus ion? That is Cohen's disease. In Cohen's disease, we'll see more H plus ion retention, more H plus ion washout. What will happen in Cohen's disease? There will be a hyperaldosteronism. I told you hyperaldosteronism function is to absorb the sodium and sodium chloride and excrete the H plus and potassium ion. Here more amount of H plus ion is getting accumulated in our body. So and there will be a, so what is happening here in a Cohen's disease? There is more amount of aldosterone. More amount of aldosterone, nothing but more amount of washout. Okay, this H plus ion will be washed out, and potassium both washout will be there. Okay, both will be washed out from the body. If there is washout of H plus ion, it will cause the alkalosis. If there is washout of the potassium, it will cause hypokalemia. Both are dangerous only. Hypokalemia and alkalosis both are dangerous only. So it should be treated immediately. How it will be treated? You will give a KCl infusion. In autonomic condition, it will cause the metabolic alkalosis. If you see like diarrhea, what will happen in diarrhea? There is loss of upper GI content. Upper GI content nothing but your GI content will be rich in a acid. They will be rich in a acid. So there will be a loss of the GI content. And if you're doing okay, if you're doing the NG or oral suctioning, you're doing NG or oral suctioning means you get metabolic alkalosis. These are the condition you can able to see metabolic alkalosis. Now we will see there in metabolic acidosis we are having two different parts. We are having two different called as I told you like anion gap we'll talk in a last session. I told you anion gap normal anion gap will be 6 to 12 milli equivalents per liter. That is your normal anion gap. If it is less than 6 milli equivalents per liter, we call it one as low anion gap. Low anion gap MA means metabolic acidosis. Metabolic acidosis. If it is more than 12 milli equivalents per liter, we call that one as hegma. What do you mean by hegma? Hegma is nothing but high anion gap metabolic acidosis. Okay, what do you mean by hegma? Hegma is nothing but high anion gap, high anion gap metabolic acidosis. And if it is normal within range of 6 to 12 milliequivalents liter, if there is altered pH, we call that one as nagma. Nagma is nothing but normal anion gap metabolic acidosis. Now we'll see hegma. I told you hegma like that is seen in case of cult. Cult is a mnemonic I made in a hegma. Okay, hegma is nothing but I told you high anion gap metabolic acidosis. Cult is nothing but K for ketosis. Ketosis is nothing but DK. You can see able to see the high anion gap metabolic acidosis. U for uremia. L for lactic acidosis. L for lactic acidosis. You can able to see the high anion gap metabolic acidosis. And T for toxins. T for toxins. You can able to see hegma. Hegma is nothing but high anion gap metabolic acidosis. They may ask you, okay, what are the conditions that will cause a high anion gap metabolic acidosis? And before talking to Negma, like how will you see anion gap? How will you get the anion gap? Because the anion gap will be calculated value. In a ABG, if we see it will give a calculated value. How are you going to check the anion gap? By there is a formula. Okay, there is a formula called as okay. We have to add the cation, sodium, sodium level. Okay, on ABG you will get a sodium only. We have to add that. How to subtract with the negative ions like bicarbonate plus chloride. If you doing this, okay, if you're adding bicarbonate plus chloride and if subtracting with the sodium, you will get anion gap. You will get the anion gap. Normally, I will tell you, okay, normal sodium level will be take 140. You take the normal PCO2 of 22 and plus like normal chloride you take 100. So what you will get if you subtracting 120, 140 minus in 122, you will get around like 18. You will get the anion gap. So it is an hegma. Okay, it is an hegma. We can say this one is high anion gap metabolic acidosis because 18 is more than 12. Okay, it's more than 12. We can call this one as hegma. That's how we can check the anion gap. Now we'll see nagma. What do you mean by nagma? Nagma is nothing but normal anion gap metabolic acidosis. There is a mnemonic called as Dr. Fuse. Dr. Fuse is nothing but D for diarrhea. In diarrhea, we can able to see normal anion gap metabolic acidosis. R is for renal tubular acidosis. Renal tubular acidosis, we can able to see nagma. F is for fistula. Anal fistula, we can able to see nagma. Normal anion gap metabolic acidosis. U for U and S for uro sigmoidostoma. urosigmoidostoma, you can able to see normal anemia of metabolic acidosis. That finishes your ABG series. Metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. Thank you for watching it. Hi, welcome you all for the KNO classes. This is your Nagraj, your NORCET mentor and NORCET guide. I'll welcome you all for the this ABG classes. In this video note, we're going to deal with the some concept, okay, some concept related to the ABG. If you see like NORCET 7 means they asked like so many questions relating to the ABG. Particularly they asking you like Allen test in JIPMA skill test. Also they asked the Allen test and modified Allen test. If you see this ABG is very important topic for all your examinations. You must do read with the like ABGs. You just be clear all the concept relating to the ABG. Once you clear the this topic ABG means like once you settle down the ABG topic, ABG concept, you can able to crack any examination because like in an examination directly some 3 to 4 questions will be striking from the ABG topic only. This is very like important topic you must know. Be sit with me take a book, take a notebook, take a notes of it. We'll discuss so many MCQs. We'll discuss the so many concept regarding the ABGs. Okay, once we'll settle the whole topic. Okay, once we'll settle the whole topic of ABG. Okay, without delay, we'll start today's section. That is our atrial blood gas analysis. Now we'll see like some MCQs. After that, we'll move towards the like theoretic concept, some theory concept related to the arterial blood gas analysis. So first question is here in front of you. That is a nursing officer was performing a ABC sampling in a ICU, and posted nursing officer like is taking a ABC sampling. So before taking a sample, he puncturing the artery. Before performing the ABC sampling, he performs modified Allen test. Okay, if you see here, the key point is modified Allen test in any examination. Okay, if examiner is asking you question, okay, if you are sitting in front of desk, you always keep in mind that you always keep in mind that you have to you have to note down the key points. Here key point is Allen test. Okay, modified Allen test. Okay, here key point is modified. Okay, especially I'm stressing out here. What I'm stressing here the modified. Okay, modified Allen test. So what is the purpose of performing this test? Okay, the examiner is asking. Okay, the examiner is asking you what is the purpose? Why we have to do the a modified Allen test before ABC sampling? Okay, your options are: option A is to check the artery patency. Option B is to check the ulnar artery patency. Option C is collateral circulation, for checking the collateral circulation. Option D is to checking the venous filling. Venous filling. We see, okay, we can clearly, okay, if anybody, just normal person is sitting in examination, we can clearly eliminate option number D, because here we are talking about arterial. So there is no role of venous. So we can clearly, okay, we can eliminate the option D. So it is not at all linked to our topic. Now let's see option remaining options. First one, we'll check to check the radial arterial patency. No, never, because if we see like Allen test, how will we perform the Allen test? We'll tell the patient to close, make a fist or make a clenched hand. Then we'll do what we'll do. Then we'll compress the both radial artery and ulnar artery. Okay, I'm talking about Allen test. Okay, we'll compress the we'll compress the radial artery and ulnar artery, and we'll see, okay, when the hand will turn to pale color. Okay, if turning to pale color means I'm compressing both ulnar artery and radial artery. So after that, what we'll do, after hand will turn to pale color, I will tell, okay, I'll release the compression and I'll tell the attendant, I'll tell the patient to open the fist. Okay, after opening fist, if you see the redness or pinkishness means that is indicating positive Allen test. Okay, this is done to check the collateral circulation, means radial artery patency and ulnar artery patency. But here I told you, I stressed here modified Allen test. Okay, if you see in modified Allen test, what they will do in modified Allen test, will compress only the radial artery. Okay, will compress the only radial artery, and after that, okay, we'll compress the radial artery for 40 to 60 seconds. Okay, for 1 minute we'll compress the radial artery, and we'll see whether the hand is turning to pale color or not. If that turning to pale color, it indicate negative Allen test. Okay, if it is not turning to pale color, it indicate positive Allen test, means normal. Okay, you are having ulnar artery patency, or ulnar artery is having adequate blood flow. So I'm telling you, okay, modified Allen test, we are compressing the radial artery to see the patency, to see the blood flow through the ulnar artery. Okay, that is your That's your right option. Okay, option number B, Bombay, B for Bombay, to check the ulnar artery patency. Okay, to check the ulnar artery patency, we are performing the modified Allen test. Okay, that is what your modified Allen test is the answer. Okay, to check the ulnar artery patency only, we want to perform the modified Allen test. Okay. Now let's see, like this one is your first question of your this section. Now we'll move to second question. That is option question number two. Which of the following condition would nursing officer, okay, would nursing officer recognize as the contributing factor of developing the respiratory acidosis? Okay, respiratory acidosis. What will happen in respiratory acidosis? If we see means the pH will decrease, means pH will decrease, means decrease, how much decrease? This will be less than 7.34. That is your like respiratory opposite. Respiratory will be opposite, metabolic always will be equal. Okay, Rome. There is a Rome criteria. Rome is respiratory opposite and metabolic equals, means in case of respiratory pathology, pH will be pH and PaO2 will be inversely related. Now we'll see. Okay, examiner is asking you what are the like factors, what are the disease condition. Okay, what are the condition that will contribute for a respiratory acidosis? First option is emphysema. If you see the pathophysiology of emphysema, what will happen? There will be a loss of bronchial wall. Okay, there will be a loss of alveolar wall. What will happen here? There will be a loss of alveolar wall. Okay, the bronchial wall. So what will happen? There will be dilated alveoli. There will be dilated acinus. There will be dilated alveoli. Here, what will happen? The person will try to inspiration. Inspiration is active process, so inspiration happening properly. But expiration, okay, while expiration is a passive process. So there will be retention. There will be retention of CO2. If there is a retention of CO2 is there, means what will happen? It will bind with the HCO3, so it will form bicarbonic acid H2CO3. It will form the, if there is a retention of a CO2, it will form bicarbonic acid. Bicarbonic acid means, as name itself suggests, acid. Bicarbonic acid. Bicarbonic acid, as name itself says, acid. Acid means more H plus ion. More H plus ion, nothing but reduced pH. So it will cause a respiratory acidosis. Okay, this one is the right option. We are selecting emphysema. If you see like other options, remaining option B, hyperventilation. If patient is having hyperventilation, in case of fever, in case of hypoxia, patient will struggle. Okay, will be having air hunger. That's why he will be having more respiratory rate, more respiratory depth will be there. That's what we call as hyperventilation. In hyperventilation, what will happen? There will be a PCO2 washout, means carbon dioxide washout will be there. If carbon dioxide washout will be there, means there is no formation of bicarbonic acid, there is no release of H plus ion. So it will cause a respiratory alkalosis. Okay, it will cause purely opposite. Okay, respiratory alkalosis. And if you see diarrhea, diarrhea is not at all related to respiratory condition. If you see diarrhea, what will be lost? We'll be losing the bicarbonic acid. We'll be losing the bicarbonate. So it will cause acidosis. It will cause the metabolic acidosis. And if you see option D, option number D, Crohn's disease. Crohn's disease is nothing but hyperaldosteronism. Hyperaldosteronism means what will happen? There will be a more sodium and water retention, and there will be more K plus and H plus excretion. H plus excretion means there will be a metabolic acidosis. Sorry, there will be metabolic alkalosis, because if you're losing H plus ion, means through the to the kidney tract, you'll be having alkalosis, because it is not at all related to respiratory acidosis. We are eliminating the Crohn's disease also. So right option will be your option number A, that is emphysema. Now we'll move to third question. That is your like we given an ABC. Okay, they given an ABC parameter. Just we have to diagnose the following ABC. What they given? If we see, go through the exam, if we go through the question, means, and given ABG of patient admitted in ICU, values as follows. Like pH. Now here, if you see pH 7.11. If you see normal pH, what it will be now, 7.34 to 7.43. So tell me that pH, does this pH is normal? 7.1 is normal? No, it is not normal. And they given one more parameter, that is PO2. PO2 will be normally around 80 to 100 mm of Hg. So here they given 90. So PO2 is normal. But if you see, PO2 is not at all related to acidosis or alkalosis. It's purely related to the ARDS and your lungs and your respiratory failures. Here we are talking about the ABG. Third parameter will be PaO2, PaCO2. PaCO2 will be normally around 35 to 45 mm of Hg. Here what they given? What the given value of 23. Okay, 23 is abnormal. And one more thing, okay, they given bicarbonate levels. Okay, they given bicarbonate levels of 12. Okay, what will be your normal bicarbonate level? That will be around 21 to 28 milliequivalents per liter. That is what your normal bicarbonate values. So they're asking you what is the following ABG will report will be showing here. Now I told you, okay, what and all like dearrange it will write in the corner of the page. Okay, pH is altered. I told you pH is inversely related to a PaCO2. So I told you, okay, we'll give a name of the disease, okay, name of the ABG, that is like primary, okay, primary will give, okay, whether it is respiratory or it is or it is metabolic one, okay. How will you get to know if there is opposite to respiratory? Okay, pH is getting altered and your PO2 is getting altered means we'll tell the whether it's respiratory or metabolic. Now we'll see here. There is a drop in pH, okay, drop in pH, reduced level of pH, and there is reduced level of PCO2, okay, PaCO2. And if you see so, but we can here it is clearly indicating that it is not at all related to the respiratory condition. If you see metabolic condition, okay, pH is now coming down and your bicarbonate is also coming down. So there is equal, okay, both arrows are going down, both arrows are going equally. So I'm telling this one is primary disorder of this condition is this one is metabolic, okay, this one is metabolic. Primary disorder is metabolic disorder. It is an metabolic disorder. Now we'll see options, okay. First I'll clear the concept, then you can see the options right now, okay. I told you, okay, here this one is a metabolic disorder. If you see clearly, the pH is less than 7.34 means we call that one as acidosis. We can give a disorder, primary disorder name, metabolic acidosis. The given ABG will be having the metabolic acidosis. Now we'll see whether it is compensated or not compensated or partially compensated. If you see now ABG, okay, pH is not corrected. pH is not corrected means we can say it is not a compensated. It is not a compensated. Now we'll see whether it is like completely uncompensated or a partially uncompensated. If you see, okay, when there is reduced, okay, when there is reduced pH, when there is reduced bicarbonate levels, when there is reduced bicarbonate level, your body should try to what to do? Try to retain, okay, try to retain the PaO2. Okay, try to retain the PaCO2. Here, if you see means PaCO2 also is abnormal. Okay, PaCO2 also abnormal means we are having all four. Okay, all four values are abnormal. Okay, your lungs is also trying to compensate, but it is not fully compensated. That's why I am giving you. Okay, I'm taking the option as partially uncompensated. Okay, your lungs is also trying. Okay, your kidney is also trying. So, but they cannot able to done. Okay, they cannot able to fully compensate for the acidosis. That's why I'm giving option choosing as partially compensated metabolic acidosis. And now we'll see other options. Okay, this one is the right option. Option number C, that is a partially compensated metabolic acidosis. Option number C, A, if you see means they are telling that compensated respiratory acidosis. We clearly ruled out here. Okay, it is in primarily related to the metabolic acidosis, no respiratory acidosis. Okay, there is no link between the metabolic and respiratory acidosis. So option number A is ruled out here. Now option number B, they're telling it is uncompensated. Okay, purely uncompensated metabolic acidosis. In purely uncompensated metabolic acidosis, there will be one parameter. Okay, your PaO2 will be normal. Okay, PCO2 and PaCO2 and bicarbonate. The two value, one will be normal. That time we'll call that one as uncompensated metabolic acidosis. Means in case of uncompensated metabolic acidosis, your PaCO2 should be normal. Okay, should be 35 to 45 mmHg. But here, if you see, means PaCO2 is dropping. It is to 23 mmHg. So I can call this one as partially compensated metabolic acidosis. And option number D, if you see, means partially compensated respiratory acidosis. So I told you it is not a primary disorder of respiratory. It is purely related to the metabolic disorder. So I am deleting option number D. Okay, this finishes your MCQ series. Now we'll see the theoretical component. I will go to the theory component of ABG parameters.